In 2016, a 58-year-old one-eyed perfume seller had a retinal detachment for which he underwent a primary retinal surgery with buccal and oil, followed by a phacoIOL SOR. He was doing quite well till the end of 2023, where he presented with this horrifying picture. The entire IOL-Bag complex had dislocated and was resting on the retina. Hence, he was advised a surgery to remove this entire IOL-Bag complex and place a secondary IOL. Now, there were a few unseen challenges, as the 3 and 9 position ocular surface was already scarred because of the previous buckle. Hence, I decided to enter via the superotemporal quadrant, remove the bag IOL complex and place a new SFIOL in a way that the haptics can be tucked at 1 and 7 o'clock. Yes, it was challenging and unconventional, but this was our best shot. The surgery was initiated by placing a 25 gauge infusion, and 2 localized peritomies were made at 1 and 7 o'clock. An RK marker was used to make 2 specific holes at 1 and 7 o'clock at a distance of 1.5 mm from the limbus. Now, 2 scleral pockets were made right besides the hole with the help of a crescent knife. The next step was to make the other 2 ports, preferably at 10 and 2 o'clock. Now, a superotemporal conjunctival peritomy was done and corneoscleral tunnel was made. Since this was already a previously vitrectomized eye, there was no additional need to do a vitrectomy. Once the sclerocorneal tunnel was made, the endothelium was coated with viscoelastic. As I went inside, I could see a nicely attached retina, a good buccal effect, and our culprit, the bag IOL complex, lying right there on the macular surface. The IOL bag complex was lifted with the help of vacuum in the cutter, and once it was brought in the anterior vitreous phase, it was held from the other end by a VR forceps. Once it appeared stable, a McPherson forceps was used to grab it and very gently get it out of the corneoscleral tunnel. There we have a beautiful picture of the devil of the surgery. The next step was to put an SFIOL. Hence, an X-net needle was used and the tip of the needle was brought out. Now, the first haptic or the leading haptic of a 3-piece IOL was embedded in the needle and it was gently pushed inside. Simultaneously, the haptic or the needle was taken out from the other end, along with placing the silicone stopper so that it does not fall back. A match script forceps was used from the other end and the other haptic was removed from the hole and it was snugly fitted or tucked inside the scleral pockets that were previously made. The SFIOL looked absolutely stable. A single tunnel suture was taken and the opened up peritomies were closed with the help of fibrin glue. A month later, his only seeing eye had a wonderful vision and he bestowed his gratitude by gifting us a perfume from his special collection on the day of Ramadan. Unconventional situations demand innovative surgical measures, and this was truly a testament of that. Thank you very much.